Today, we're going to talk about aligning the patient journey with HITRUST and the CSF. It's an interesting topic as we started to ideate what would be different, what we should really talk about. One of the things that I've realized throughout the years is the HITRUST Common Security Framework, the whole body of work, the shared responsibility models have evolved immensely well and very effectively, but we've always spoken about it from a framework point of view and how to manage your controls and report on them. And what we need to see more of now is how do we really apply that in real world scenarios. And this is an attempt to apply that and for you to come along with us on that journey. So I will start with the introductions. Again, my name is Hector Rodriguez. I am at AWS. I've been there for about 3 years. Before that, I was at Microsoft for about 15 years. I also have worked with Oracle and other organizations. I started working in cloud computing when it was launched at Microsoft, when we launched even before it was called Azure. And at that time, I was building a common security framework because I realized that that vendors in general, especially cloud vendors, had no clue what to do in healthcare or how to meet the security, privacy, and compliance requirements. And so as I started to research the work I was doing, I found HITRUST. I became part of the cloud subcommittee with Dan Nutkiss and the others at the beginning. And I don't know, 12, 13 years later, here I still am. So that's me. Chris, I'm going to ask you to introduce yourself quickly.
Thanks, Hector. Hi, everyone. My name is Chris Bombani. I'm a healthcare practice manager. I've been with AWS for about 2 years and 4 months. Prior to that, I come from the healthcare sector, so my heart is with the patient and the provider. And I served as over at Columbia University Medical Center as the deputy CIO. Ed, I'll pass it over to you.
Thanks, Chris. Ed Schreibman. I am also with AWS's Security Assurance Services team. I've spent my career in healthcare in a variety of different roles, with business process outsourcing to doing consulting. My first journey with HITRUST was on the entity side about 10 years ago, and it was definitely a little bit more of a grind than it hopefully is for you folks today, and looking forward to talking to you more today.
It takes a while, doesn't it, Ed? Thanks. So we are going to talk a little bit about the triple aim or the quadruple aim. Is everyone familiar with the quadruple aim? Some people are. To some people, it's new in healthcare. One of the things that I will say, as practitioners of HITRUST, of cybersecurity, of industry, it is critical that we align with our customers' missions. We all know that. In healthcare, that mission is quite consistent, regardless of the wording that's used. I do this all around the world, and if I'm in India, in Spain, in South America, all healthcare organizations want to improve the patient experience, to drive better outcomes, to drive affordability. Chris will talk us through a little bit more of the triple aim, or what's now called the quadruple aim, and there is a fifth one being added. I'm just not there yet. And then we'll look at that journey and the role of HITRUST that Chris and Ed will continue to walk us through. Before we do that, though, I want you to imagine with me, and I tell this story about John Lennon. I've used this analogy quite a few times, but when John Lennon was originally asked what that song Imagine was about, it was really simple for him. He was just asking us to imagine a world or a place where things that divide us, and he used religion in possession, did not exist. We kind of have that issue in healthcare. Healthcare is a very complex place. There's a lot of discussions that can divide us. Anything from the old question that still comes up, who owns the patient data? That's an amazing discussion. That can take days to resolve, and by the way, it's never been resolved. But the song was originally written actually as a political message, but the underlying question that Lennon was really asking is, if you want something like peace in this case, or in my case, in our case, like efficient and effective healthcare, you have to imagine it first. And that's really what we're asking you to do in this room today. And as we move forward, imagine a place where we are driving these better experiences, where we're driving these quadruple aim objectives, where we're enabling organizations to meet or exceed those requirements, but all beginning with a framework of security, privacy, and compliance, a framework like HITRUST. And I'll share a quick story before we jump into the quadruple aim. Yesterday, I was with a security organization at a medical center, and the same questions come up. They're starting by trying to solve issues, and Gen AI is a huge issue, a huge question right now, but they have no framework in place yet. They're still figuring out their cloud journey, and they'll say we have a cloud-first strategy, but we don't even know what that means. Where do we begin? You begin with a framework. You begin with the HITRUST CSF, with understanding NIST, or today with zero trust principles. But you've got to get that foundation as solid as possible in order to be able to move forward. And you'll see that that's one of the things we emphasize throughout this scenario, which is a patient journey. The other thing I'll add, a lot of my discussions have moved into this topic of being more resilient, improving your security posture as an organization. Well, the only way you're going to be able to do that, again, is by going back to your control framework and being able to measure it, to improve it, and to continuously monitor it using AI and machine learning, using these modern technologies. But our data is trying to tell us something, trying to tell us how to get better at what we do. We have to be better listeners. We have to have better solutions in place. But I keep emphasizing this. We have to align it with the problem we're trying to solve. And in healthcare, the problem we're trying to solve today is a better patient journey for all of us as healthcare consumers. So Chris, I'm going to hand it off to you because I know I can talk forever and we only have 45 minutes.
Sure, thanks, Hector. Thank you. Hi, everyone. So this slide just sums up what Hector was speaking about in terms of the quadruple aim. And as I briefly mentioned, I've always worked in health technology, but pretty much on the provider side. So for me, my heart is always with the patient and the provider, and I tend to be the voice of the customer. My most recent organization prior to AWS, when we did any technology implementation, there are all those arguments that go into all those discussions about what are we going to do, what is our strategy, as Hector mentioned, and do we need to do this? So for us, one thing that I learned from that organization was we decided that we would put the patient at the front of everything we're doing. So if this technology implementation is not going to improve access to care for the patient experience, do we need to do this? Why are we doing this? And we work backwards from there. So in terms of the quadruple aim, this touches on that. So it's multifaceted. We want to take a look at, when we think about security, compliance, privacy, oftentimes we are thinking about specific areas and controls and very specific areas that we want to focus on, but we want to just take a step back and think about it from the overall healthcare perspective. And how is what we're doing with HITRUST going to improve population health? How is it going to help with the cost issue in healthcare? Is it going to improve the patient experience? How about the care team experience? And then how that all comes together is the quadruple aim. So we'll talk a little bit more about that in our next slide. So let's talk a little bit about Paula. Paula is our fictitious patient, and we're going to talk a little bit about her journey and how HITRUST can help improve the patient experience. So Paula is a lot of things. She is a mom to two wonderful kids in junior high. She is a wonderful wife to her loving, devoted husband, Peter. So we have Peter and Paula. She's also works full-time and has a demanding job. So it sounds like Paula is killing it in all things in life and living her best life. And Paula and her husband, they do a pretty good job at juggling, which is getting everything done, which is pretty much like all of us, right? So we'll talk a little bit more about Paula, now that you have a sense of who she is. So Paula, she is pretty well balanced, tries to take care of herself the best that she can. But the past couple of months, she has noticed that She's been waking up in the middle of the night, having to use the restroom. She is hungrier than usual, and she's also thirstier than usual. So this goes on for about a couple months, and she says, okay, I think I'm gonna go see my doctor just to see if everything's okay. So Paula's been seeing the same family practitioner for years. She loves her. Why change, right? Her doctor, whose name is Dr. Care, has moved offices and is almost an hour away from her. But Paula still wants to go to her because she's just been monitoring her for years. So Paula goes to visit Dr. Care, who then orders some lab work on her just to kind of better understand why she has these symptoms. So Dr. Care enters this information into the electronic medical record, which houses all of Paula's data, and places lab work entries, which flow through to the system where Paula is going to have her lab work done. Paula then, she goes home, talks to Dr. Care. Dr. Care says, let's have a virtual visit. That way you don't have to drive all the way in. You don't have to take time off from work. This doesn't have to take you away from your kids or your husband. So now Paula, she signs up for the portal, patient portal, a little skeptical, like, okay, do I really want my information out there, wherever that is? Do I really want to do this virtually? I love going to see my doctor and having those in-person conversations. But she does have a lot of responsibilities in life and says, you know what, let's give it a shot. If my doctor trusts this, I trust my doctor. So Paula and her doctor then have a telehealth visit, and she doesn't get the greatest news, but she finds out that she does have a chronic condition that she needs to manage. But on the positive side, she's able to work with her doctor to then come up with a structure where they can have virtual health in place, where she can have continuous visits with a nutritionist who's gonna help her manage her nutrition. She has a system where she's gonna take virtual fitness classes just to help her get into better shape. And so she has a good plan with her doctor and is starting to embrace healthcare from home. Dr. Care's office also sends her a device, part of remote patient monitoring, which I'm sure a lot of you have heard of. Who here has heard of that? Okay, all right, most of the group. So when I worked in the hospital setting, I saw it firsthand, probably the first time 15 years ago, where the physician at hand took an actual device, and I didn't know what it was at that time, and gave it to the patient, and I was like, what is that? And I was implementing Epic, so that's all I was there for. And I'm like, what's going on? But we had to connect everything, and the patient took it home and wore it, and it was able to, that information then was stored in the device, and the doctor was able to analyze it later for patient care. Now, in this new imagined world, as Hector mentioned, the information from the device will automatically flow to the doctor's office. So Dr. Care is able to read all the information without Paula having to come back into the office. Paula then continues to have these virtual health visits with her nutritionist. She takes these Zoom classes, which have been helping her. And so she's been doing that monthly. So then to wrap this up, Paula is now getting acclimated to having more access to care from home. And she actually likes it because it's convenient. And so she's more comfortable. She gets text message reminders and email reminders that are initiated through her patient portal, all through the EMR, securely initiated on her cell phone. And then lastly, for her 3-month follow-up, Paula does go into the office. She meets with Dr. Care, and though she received news that she had a chronic condition, she was successfully able to manage it from her home in collaboration with her care team. So that was a lot of information, but that's Paula's journey. And on that note, just to sum it up here, all of these devices, all of this interoperable, the flow, it's all done securely, thanks to the work that we do. And so through that, we are able to improve the patient experience, giving them that sense of comfort that their data is secure. We're able to work towards the greater goal of population health. Did we improve population health by that one person? No, but if we do that for multiple patients, will we? Yes. Cost reduction, this is less expensive. Paula doesn't have to pay for gas to drive for for an hour, take off from work. Paula's practice and care team, it's more efficient for them to see patients virtually when they can. The provider experience, this is also, this is improved from being able to just analyze data remotely, not having to have Paula come into the office. And third-party risk management. So this is another area where HITRUST comes into play, where we ensure our vendors are leveraging, have become validated and have gone through all the controls and checks to make sure that the patient experience and the whole healthcare journey is secure. And on that note, I will pass it over to Ed, who'll go into a little bit more detail about the role of HITRUST.
Thanks, Chris. And as we start to dive in a little deeper, please, this will definitely work great as a dialogue. So if there's something that resonates, let me know. We'll try to call it back. I wanted to hop back to this slide. As Chris talked about this from the patient's perspective, I'm going to put my HITRUST hat on, and I see a fairly large set of systems in scope, and in 45 minutes will be a bit of a challenge to go through all of it. So I'd like to do a bit of a deep dive. So in a high level, Paula has a lot of different types of interactions with technology, and we talked about some text messaging, and we're all thinking in the back of our minds, what are the risks and controls? Text messaging, remote monitoring, televisit portal scheduling, and third parties. Let's do a little bit of a deep dive just on the electronic registration piece and talk about where it is today and what Paula imagines it could be like. When I started in healthcare governance, risk, and compliance, one of my tasks that my boss said about was always working backwards from a yes. You know, we can't do that. We need to imagine that we can do that. And let the control frameworks guide us, but where we hit our head against the wall, let's work collaboratively to see if that framework needs to change. So Paula, her current registration experience, I need to have a call out to the medical provider. They have a 5-star rated registration application that they have deployed. It's meeting all of their security, risk, compliance, and patient experience metrics that they set out. So they're very protective of making sure that any change is made. Obviously, we need to make sure we've got compliance, security, risk, and privacy addressed, but we need to ensure that our patient experience does not take a step back if we make any of those type of changes. And the current way they deploy it is provider has own tablets, so they can put their facility controls on it. They limit this registration piece to only within the network of the facility. And Paula is looking for a more personal experience and at the same time keeping our health information secure and private at the same time. And I want to talk a little bit quickly about why and why she has these asks. Chris introduced you to Paula and told you a little bit about her. What she didn't mention is she does have several significant accessibility issues that she manages quite well, and she manages those especially well with her devices. Certainly the facility-owned application is designed with accessibility principles in mind, but just having to go in to the facility, modify the fonts, every time she registers is a bit of a pain point when she's got this already handled. Also, she likes a keyboard, so she's a little bit more comfortable working on a laptop, and her daughter, Paula and Peter's daughter, who obviously name is Mary, wants a mobile device. Thank you very much. I'll be at Buc-ee's tonight at 8 p.m. She's living an hour away. Working only within the network's facility also isn't a great advantage for Paula. She'd like to do this remotely. So here are a couple of questions. I'd like to open it up. We're certainly not going to go into the unique ID or BUIDs, but from your HITRUST hat, from your perspective as folks working governance, risk, and compliance, these two things, they, from a layperson, seem pretty reasonable. What are the changes? What would these changes, if we imagine them, how would they impact our security and risk posture? And what are some of the areas that we would need to make sure we would have to have compensating controls or modify? There'll be a Bucky sticker for the first question of the day. So obviously, we've got a couple, and we're not going to go into that spreadsheet, I promise. I just want to hit on a couple of things that we now need to think about and collaborate on. And we need to understand that these items may not fit perfectly within our current risk framework, and that's okay. If we find that, we're going to work with our external assessors, with HITRUST, and make sure that we can address some of these concerns. And a lot of this may be in terms of just appropriately scoping what is intended by that rule, whether it needs to apply or whatnot. Portable media security is the first one that obviously comes to mind because we're talking about a portable device. So there are going to be a few items that we need to make sure. How is the organization going to identify and encrypt a mobile device if that mobile device that processes sensitive information is not ours? Do we have to encrypt that device? Is there a different type of control we can apply to a personal device that would meet the same rigorous standards that the facility has? Hopefully we're not looking for black and white clear-cut answers that you can take back, because there aren't going to be any easy answers. And again, please feel free to interrupt me at any time if we should dive in on anything deep. So we've got some framework rules that ensure that we're going to restrict the use of the media and personally owned devices in an organizational setting. How does this apply when we are looking to provide this care in a way that really works for Paula, who now looks completely different than slide one? Mobile device. So the item that is so often not given the weight that it deserves is education, training, and awareness. I am often paired up with folks in technologists, builders, infrastructure folks, and quite frankly, often we're not emphasizing education, training, and awareness enough. We have a lot of great guidance from HITRUST in terms of how we're going to onboard our employees, how we're going to onboard our third parties. Do we have an obligation? Do we have a risk to extend some of that training, some of that patient education to folks as they start to bring their own devices into the system? I think we do. So I would certainly hope that as part of this effort to modernize our infrastructure, we're also looking at how we're going to communicate the benefits, but also some of the risks and responsibilities that our patients, such as Paula, have as they begin this journey. I have a bunch of other items that caught my eye. The network. We went from having everything in and out in a nice, neat box. We've now expanded that. How do we control that? Are there any limitations? Do we want to, for example, make sure that, yeah, she can do it from her home, but we're going to require them to engage through some type of a zero trust mechanism to be able to proceed. Again, just to see if I can stimulate a conversation, and I know you can't read read these. Any other, when this is based off of a real case of a modernization, and I think I've got probably 7 examples that I pasted out. I believe the assessment I had 39 specific items that we needed to put onto the risk register. We had to assess and analyze, and frankly, lose a lot of sleep. Any other items that would come to mind?
I think is it still on? Yeah. One of the things I'll go back to is the network. So I'm in the field a lot, talk to a lot of security leaders and digital transformation officers across these organizations. And one of the biggest challenges they're having and questions they're asking is, how do we extend the provider network into the patient home if you're going to effectively do remote patient monitoring? And by the way, remote patient monitoring is a huge opportunity. The markets and markets research shows from a revenue point of view, it's about a $300 billion opportunity. Device manufacturers are also driving another $200 to $300 billion. So there's a win for everybody in this equation, and it is critical that we're able to deliver on that. But the way that I look at that question about extending the network is really, how would you use a framework like HITRUST to make sure that you can securely extend those services into the patient's home? So you're taking the services to the patient, not bringing your patient to the services. Medical devices is a great area to focus on as, again, this next evolution of the framework starts to adopt what the FDA just released in terms of cybersecurity for medical devices, what the European Union, where GDPR is going with what we have to do to secure medical devices. So we can use frameworks to really prepare the answers for those questions. Also, when I work with CISOs and their architects, Ed had said something that is really critical. I ask them to focus on what yes looks like. Unfortunately, CISOs are designed and taught to say no. And I even had this yesterday at my meetings where the CIO points to the CISO and says, his job is to say no to me and to make it difficult. We'll start with what yes looks like. And that's, again, where the risk controls that you're running into for devices, for extending the network, extending the identity parameters, really help you define the control objectives, define the shared responsibility, and the education side. When patients learn that security is also partly their responsibility, they will do the right things. Most of us will do the right things. There's always one person that'll click, right? But for the most part, that's how you break it down into the work. And I love the work that Ed and Chris do in terms of diving deep into the specifics of HITRUST and the CSF and how they apply to the different parts of the scenario. The last thing I'll say about that whole scenario is it's not applying all 1,500 or 2,000 plus controls to every part of the scenario. It's making sure you have the right controls aligned with that part of the journey in the scenario. Because there's no way you're ever going to make everything compliant with 2,000 plus controls. That's just not going to happen. And the different controls are there, and they're very purposeful. And it is our work and our job, and we're working on this to make sure we align the right controls with the right requirements that are needed for those services.
Thank you, Hector. And the CISO's job was to say no. The right answer is just to say maybe, it depends. One thing that popped up when you talk about a medical device versus a tool to register is data classification. Having a one fit applies to all is not going to work well. I've had too many experiences where data classifications were not tiered. There was the in-scope stuff and everything else. But when we're talking about bifurcating a network, there's a different set of risk associated with the fact that I am acknowledging that I'm going to be there in 20 minutes, from having my blood glucose levels transmitted in an HLS format, in a standardized format, which may have some HIPAA implications. It may need to be stored. And we need to make sure that we're taking not a one-size-fits-all, but taking a look at what are we imagining and how do we get there without trying to have that one fit size approach. We're going to move on and start to wrap up our short session. And again, would definitely appreciate any comments or feedback from the audience. So our concluding thoughts, we want to intertwine the modern patient journey with the quadruple aim and HITRUST CSF. That includes collaborating with everyone in the organization. If I am responsible for assuring or doing an assessment, if I need a piece of information that's related to HR, let's figure out how we can collaborate directly so that we're not having everything funnel through the infrastructure lead because we think they're the only person that has a lot of hard work to do. Let's envision and build that system so that we end up with something that's efficient and secure. We always did that, but let's also make sure we've got an equitable system and that we're listening to our patients. And that is going to go off for everybody. It must be 2:20 Eastern Time. Welcome to the emergency alert. We can build that ecosystem with security, privacy, compliance, and it can support that vision. We can get to yes. We may not be able to get to yes tomorrow, and it may not be easy, and we may not even have the right team today, but we can definitely get there. I'm going to turn it back to Chris and Hector to help wrap things up in the few minutes we've got.
Yeah, thanks, Ed. I actually have a question for the group. So after hearing this, I would love to hear, is this achievable? Is it achievable but in 100 years? Where do we see any holes? And just to get any thoughts, or, in case you just love the concept, just love to hear any feedback. Yes?
I certainly love the concept, and I know, Hector, we've talked before, like when you start talking about a system that goes into the home, remote monitoring, like, is this because you've had great experience with the shared responsibility model. Now we've got shared responsibility across those that are providing the technology stack, those that are implementing the stack, and then individuals, right? So when I take the device home, monitor my blood pressure or whatever. So does that now extend to device manufacturers? Like, is that the way to get to
That is it's interesting because that is the goal when we work with the Medtronics of the world or even the Strykers and so on. One of the things, and I'm glad you bring that up, where I've been able to really advance the conversation with those organizations is actually using shared responsibility as the model so that everybody understands their responsibility. When we originally designed the shared responsibility model, actually I was at Microsoft and we started working on some of this with HITRUST and our Azure security team at the time. And we've done the same thing with AWS and others. There were only two parties in the shared responsibility model. There's actually multiple, depending on what problem you're trying to solve. There are those third-party partners. There are the patients themselves. And I'm not saying that you're going to educate the patients on HITRUST CSF. That's not the point. It's actually educating them on what their responsibility is. But the device vendors, absolutely critical. And one of the things that we're doing on AWS is focusing on the device vendors, focusing on standardization of some of the device protocols for how data is shared. But I'm going to take it back to one other thing, too. In the conversations, as CISOs, we're trained to focus on confidentiality and integrity and availability. It's called the CIA triad. That triad actually flows really well into well, how do you do that by following HITRUST CSF, HITRUST principles at each level of shared responsibility of a device? And again, so when you build out really that RACI matrix, everybody starts to understand what their role is, what their responsibility. But the device manufacturers are catching on. We do have more and more of them who follow the framework and are willing to do the right thing. But that conversation is still in its infancy, and particularly, again, with the new cybersecurity rules for devices from federal governments.
It's interesting, and thanks for the education plug. I saw a demo for folks that had chronic renal issues, and it was a remote diagnostic solution. So it wasn't a passive monitoring, but there was an active set of motions that the person needs to do to make sure that on the telehealth provider side, oncologist is able to see the image that they want. I mean, you do not just go in with a ultrasound wand and know what you are doing. So when you talk about education and when you talk about where does it lie on the shared responsibility matrix, that really does open up an entire new set of almost clinical responsibility to ensure that the end user knows what they're doing. If it's, again, I pick the easy one, registration, even monitoring of glucose, make sure that they're wearing it, that they're not wearing it, that the kid's not messing around with it, becomes essential. There's one thought that I don't think we've expressed, but does harmonize with HITRUST, to use a HITRUST word, is when first approaching HITRUST, we always talk about getting buy-in from above. I can't imagine that this journey being initiated successfully from the patient experience team or the registration team or the network team or the infrastructure team. This really would need to be encompassing all areas of that organization, because it's not only a technology change, it's truly a cultural change that we're looking to make.
And Ed, if you can back up to the journey slide, I'm going to leave you with this thought, because this works amazingly well, and I'm doing this with the AWS IoT services team. So they've brought me onto the virtual working team as we look at remote patient monitoring solutions and partners, and we look at where digital health and digital patient experiences really are transforming. What we do, and what I would really push everybody in the room as an assessor, as a practitioner of HITRUST, but wherever you work in the healthcare industry, is draw out this picture. And then what I've done with our IoT team, and now we have an IOMT team, they got highly, highly interested in this because we started to really dig into what we need to do at each step in the process. What security controls do we need in place? What does privacy and compliance look like? How do we collect that data signal and make it part of enabling an organization to have a more holistic look at their security posture? And our overall goal on my team at AWS, it's the Worldwide Public Sector Security Team. We really have one goal overall, is to improve our customers' security posture, to make them more resilient. The only way we're going to do that is by addressing it in every step of the way. We can't just solve one of these events or activities. We have to solve them all for the right reasons. And it really changes the conversation in the room when you're working with an organization that is looking to become more resilient, to improve their security posture, but more importantly, to put these new types of digital services in place for their organizations. Because today, you're not going to walk into a hospital or even a health plan. Pharmas are doing remote clinical trials. They're not going to ask you how they should implement HITRUST CSF. They're going to ask you, how do they make their patient journey more secure so that they can enable that digital experience in a more modern world.
Great.
Chris, that's
Chris,
it.
Time check, we have...
So we have a
Thanks.
couple of minutes if there's a last question. Yeah.
The medical devices you're talking about, I guess, explaining here, they're not directly in real time, are they?
They're starting to be more real time.
I was going to say, how does that change, if it's real time, where it's 24/7 monitoring going on? Kind of a point in time right here.
An ultrasound has to be done in real time because the oncologist needs to say, go up, go, wait, I see a shadow. Well, hopefully you're not going to say I see a shadow. You need to go to the left. Real time, not only real time, but we're talking back to the CIA triad, we can't have excessive latency. So do we need to ensure that the endpoints that the patients use are giving us sufficient bandwidth to be able to do an effective job? Because we could be...
When I think of an implant, that guy needs to be monitored and let you know ahead of time you're about to have a heart attack.
Yeah, and we're starting to see more of that. There's a body of science called performance analytics, which was used in athletics first. You see it with the NFL, with the professional tennis tour. They're really good about getting real-time feedback in their movements and so on. That same technology is starting to be applied to patient monitoring capabilities. The one thing that we are also seeing is that the class of device that's going home with patients has now moved into sending class 2 or class 3 devices home. It's not just a smartwatch that monitors your heart rate. It could be something that's a bit more invasive or even life-sustaining. So we're seeing remote dialysis and glucose monitoring and things like that. And it is getting closer to real time.
And broadening that conversation to both of your points, we need to make sure we've got the risk appetite and tolerance for that. We may need to just decide this is not within our organization's risk tolerance. It's a good idea, or it may be in the future.
Absolutely. Yep. Cybersecurity is a risk process.
So what are you going to provide the patient to say besides trust me, that your data is secure? You see?
No, I think it is giving the patients the options of how they secure their devices and having more of a multiple security architecture in place. And when we look at extending Internet of Medical Things into the home, today what you really have to do, given what the device is, if it's a newer device, it becomes a little bit easier. If it's a legacy device, not so easy. But you've got to protect the network, protect the apps, protect the data, and if you can, protect the device. Now, given FDA rules and others, we're not allowed to put new software on those devices without going through a new validation process. So you've got to think differently given what the device is and so on. The other thing is when we move to more zero trust identity, now you're putting the patient in control of how their identity is managed and what type of identity policies are associated with the ability for people to access their data and to share that data. So it becomes a much more interesting and I think fulfilling conversation as we move into this new world of zero trust tenants where everything's a resource and you have to secure everything, but people have different responsibilities in that security journey.
I don't think the answer is going to be trust me from
Right,
your
it's
question
It's
or click through.
It's definitely not the answer.
And I don't think it's going to be a click-through. I think it's going to be part of extensive education that tells them, here's how this is intended to work, here are your obligations, this is where you can get additional information, but we're not just going to give you a click-through.
Yeah, well, it's almost like good housekeeping seal approval or some sort, right? That people have paid your data on, and
Yep.
this appliance has been tested, and we kind of trust that. It seems like
Well, I don't know, AWS has a lot of services under their IoT area. Having manufactured a device that used those services, there were many that were security related.
Yep.
Or secure. So, as a manufacturer, those are services they can embed in their system.
Yeah, and one of the things about AWS that really intrigued me when I joined is everything at AWS is an API. That's really where it's a microservice. But because of that, we have the ability to audit and create very in-depth logs of what's going on. But that data is really security data. It's activity data. And as we move into the world of Gen AI, and we're already AI and ML, but with Gen AI on top of security data, we're going to get much better visibility into that overall security posture. And even the recent research from Gartner's and others really have focused on the impact that Gen AI is going to have on cybersecurity. And I think that's a discussion that we're going to see evolve very quickly. Even today, just being here at this event, I think I've already spoken to 2 or 3 people about that. And it's a body of work that we have to develop next is what are the real security, privacy, and compliance needs for Gen AI, for large learning models, for foundational models, but more importantly, what do outcomes now start to look like? How do we really, again, improve that security posture?
So thank you both. We are 1 minute over. I didn't want to interrupt. So I guess we can take any other quick questions or feedback if there is any, and then if not, thank you for being here.
Thank you.